Okay.
You good people? Sorry, my man. Too late here.
Usually. Once all day. Yeah. No, I don't hear I do it. She down well, thing 30 minutes. Thanks, Jack Daniel. Speaking.
Hmm.
Yeah, my body responds. Yeah.
Well,
That
that's for the breathing, right?
he really helped that. I was on for like all my shots.
Oh, who's feeling lucky today?
Sure.
Anybody out there feeling lucky?
How's you're outside of the gym?
Almost safe.
Nobody. Huh. Who thinks they're doing the oral practical first? Anybody feeling lucky like they're gonna be that first person to go?
It's not all.
Is my volume not working?
Like,
Dang it, everything.
put it inside me.
Oh, it's working. There's other people in the room. We can hear it all.
Okay, good. All right, can you hear people talking in the background?
Yeah.
Okay, I can shut the door. All right, hope that should dampen it. It's just me. So, Abbie, I have a 51-year-old male who's coming to see you. And he's coming because he's a physician. He's, I don't know, he's 5'3" or 6'3". He has been having anterior hip pain after running about a month ago, and it hasn't gotten any better. It's been irritable. It came on all of a sudden. It's his first episode. And, every time he runs, it gets worse. He can feel it. It's irritable. It's can be irritable throughout his day when he gets up, when he's walking long, because he works in a big hospital, when he's doing long walks between places, the hip is irritable to him. Tell me a little bit about what you're thinking. What are the potential things this could be off the top of your head?
Um, Anterior hip pain. We could have. Oh my gosh, I haven't gone through hip in a while. This is bad. Um, the first thing that comes to my mind is always like a UFR, but that's probably not it.
That would be an etiology or
Okay.
a potential cause. And never think of a UFR as being like, oh, that's the diagnosis. I want a pathoanatomical diagnosis, and then we can get into what etiologies are. But it's very normal to think that way early on. So just kind of always know whenever you think of that, think, okay, I'm in the etiologies now. Let me back it up and get a pathoanatomical. So what you want to do with this is, what are the most likely things that would be causing anterior hip pain? Break it down to that. Take away the person individually. He's 51. He's not 21. So that's going to tell you a few things. What do we have?
I mean, he could have arthritis. Is that what you're talking about? I mean, that's
Yep.
still an etiology, or it's not. Okay.
He could have hip arthrosis, which isn't that would be basically the pathoanatomical diagnosis, not an etiology. Think about it that way.
Okay.
Okay. What next?
Um, 51. I mean, it could be coming from his back. It could be a back issue that's leading to his hip, or there could be.
So you're thinking kind of a referred radicular pain? That would be one.
It could also be coming from the bottom up.
What else? Anterior hip pain.
I'm stuck.
So far you have 2, and I could think of about 3 more.
I'm sure you
That's
could.
high likelihood.
Can I popcorn this to another person?
Oh, no, Abby, it's all you today. It's you and
Oh,
me.
really?
You
Okay.
and me.
This is
First
great.
round of these. We'll do a lot of these between 8 and now the 8 and the exam.
Mhm. Okay, so could he have a like muscle strain?
Muscle strain. And everyone else is gonna be so easy to come up with these answers when it's not you.
Yeah,
But don't be stressed about it. We're gonna kind of just walk through it.
I'm
We have
far
muscle
from
strain. What else in
right
the
now.
anterior hip? What's the most common thing you see in
Um,
your anterior hip pain patients?
I don't know, like a lot of times they, I don't know, I just had one. I'm thinking more like range of motion things. Like they're like lacking hip extension that's causing like compensation in the anterior
Etiology.
portion of the hip.
Etiology. What would cause a lack of hip range of motion, though? Let's do
Avascular
that.
necrosis.
I'm
I have
sorry.
2 of those. I said avascular necrosis.
E1 is this likely what he has, but we could put it in the list. I would put it way down my list.
Right.
Think about it. Here's my list. Here's AVN. And with that would
All the
have
way
its
down
own
there.
questions.
Right. What else could be wrong with the hip if they have anterior hip pain?
Common one probably has it given his age. And I would put it right here.
Hmm. You're giving me a lot of hints. I'm just not picking up on them, Dave.
No, it's so tough to be the one getting questioned, isn't it? So think working in and out. We have arthrosis. That's joint. That's articular. I'm coming out. My next structure is going to be probably labral capsular.
Yeah. Okay. Like a labral tear or just like a
Yeah,
capsular
you could have a
issue?
labral tear. You could have a capsular issue where you're getting a breakdown of the anterior hip. And that capsule tends can be hypermobile if he's got something going on there. So I got something going on in the anterior hip there. We have strain or a muscle strain, right? Isn't that kind of the next layer if we think about it?
Mm-hmm.
So we have something that's articular, which is like arthrosis, way down the list, maybe stress fracture. It's probably going to be here. Because he's having pain every time he loads, and when he runs, it gets better when he's not. It's painfully sitting up. It's possible, but I'd have to sort that.
Right.
We have a strain, a muscular strain, kind of working out the different layers. And we have radicular pain. Okay. Which hypothesis? What do you think he has?
With him being 51, I mean, it kind of sounds like he just started running. Like,
He's been running for
kind
30
of,
years.
oh, okay. Well, you didn't tell me that.
Are you
I had
talking into your
Hector running
fist?
a month ago. No, I'm just making sure. I got to clear it
Yeah.
all up. Because if I would have thought that it'd be more of a capsular issue if he just like hopped off the couch and started running, versus I think it's more of a joint issue if he's been running for 30 years.
Okay, quick kill on the clock. Arthrosis. What would arthrosis look like if you think that is what he has? Or do you think he has one of the other 4 on the top?
If he had arthrosis, his pain would be, it wouldn't be as much, like it would be painful in the morning, but not throughout the day as much, and more towards the end of his day after prolonged loading.
Hmm. How would it respond to activity?
Weight bearing activity, prolonged weight bearing activity would probably increase the pain, but any non weight bearing sitting close or open chain activities shouldn't really increase the pain.
It's true to a degree, but many times, like a straight leg raise creates a lot of torque at the hip joint. So capsule labral problems really don't tolerate it very well. because there's a high degree of compression that has to occur at the hip. So yeah, I
Right.
agree in some ways, but the open chain stuff sometimes, like the long lever open chain, is irritable. Like I don't generally don't do it on hip replacement patients just because it creates a lot of torque. It's a hard moment to create in
Mhm.
there. So arthrosis patients, you might find that they have pain with that. That's just an aside. It's not a coming to where you are. So morning pain. So how would you test this for arthrosis? Yes, and say, okay, you still think it's arthritis, the morning pain's iffy. He doesn't have pain in the morning. It clears up pretty quickly once he pees and gets a cup of coffee. And he just
But I
notices it's kind of low grade.
mean, I would check range of motion, and I would check like quadrants and stuff.
Mhm.
Sorry, my computer just went down. Okay.
Okay.
So I would do
So
like quadrant
what
testing, range of motion.
what would you expect to find if this was a hip arthrosis when you did range of motion quadrants?
I would expect to find pain with the most closed pack position.
And what is that?
Um, to extension, internal rotation, and adduction.
Okay. And so you think you find the limitation and restriction? So if you had a capsular pattern, what is the kind of the classic I agree. What is the classic traditional capsular pattern? Which one would be restricted first? This was a
Extension.
severe arthrosis. Which direction is kind of classic by Cyriax as being the first restricted pattern or the restricted pattern you would see, not necessarily the first one.
Oh, would it be extension?
Now it'd be more flexion. It's kind of the early one they had.
Yeah.
So when you go into the flexion quadrant, you come up and that hip is going to arc outward as you come in. So as you bring that hip up, it's going to follow the curve and the orientation of the acetabulum. You won't be able to get into pure flexion. It's going to be tight. The capsule is going to be super tight. You're going to lack the posterior glide. So flexion, you have a capsular pattern with the classic arthritic capsular pattern flexion will be severely limited in that pattern.
Okay.
He does not have a severely limited flexion capsular pattern. He does have a restriction in extension, internal rotation, adduction, but not so much in adduction, because it is the extension and the external rotation pattern.
External rotation or internal?
I'm sorry, internal rotation.
Okay. So if they are limited in extension and internal rotation more than the adduction.
And then flexion is relatively normal with a slight lateral glide once he reaches about 90, which is a pretty normal range.
Right.
For pure hip flexion.
Mm-hmm. Okay.
So what
Am
we
I
got so
thinking
far
more of
is
a capsular issue then? Like, because the
there's
way
less
I'm
of
kind of
it's less like a capsular pattern, a classic capsular pattern that you'd see with arthrosis. So it does have a restriction in the movement of the hip.
right.
Does that make sense?
Hold on, repeat that one more time so I can hear it again.
It's not the pure kind of capsular pattern that you would see with an arthrosis in the hip, but he does have a capsular restriction in the movement of his hip.
Right.
Eric, if I'm screwing this up at any point, feel free to chime in. Or if you'd like to ask a question just for fun.
I just jumped in, so I'm not sure what we got here.
I'm torturing Abbie over a 51-year-old male who developed hip pain running a month ago. That gets worse when he runs and is irritable like throughout his day when he sits. He's a physician, so when he sits or walks between buildings, his hip is irritable, but it doesn't really tolerate running very well. It'll be sore for 2 or 3 days after.
Got it.
And we're working through the differentials on arthrosis right now. I gave her basically a non-capsular pattern of restriction of extension and internal rotation is where we are.
Okay.
All right, where are we going next, Dave?
So let's
So
talk about the
we're-
next one.
Yeah, so we're limiting extension, interrotation, and some adduction.
Mhm.
If there was in my mind, the way I'm like visualizing this, I feel like when the patient is in extension, their capsule is the most taut. Is that
Yeah.
the incorrect way of thinking about
I
it?
think about it that way as a closed back position, but we're also talking like with a arthritic capsular pattern. It's usually the flexion is usually what's been defined out. Now there's 3 different capsular patterns I could find on hip things. So depending on who you're talking to, Paris has one, Sirix has one, Kaltenborn has one, and they're all slightly different. Earl Petman has one, and the Earl Petman one and the NIAP one that you kind of derive from is that extension. I'll find that's the one I look at first is that pattern. But when I get in that internal rotation extension adduction pattern, it's the end range of stride. Now I can tell you when you do that, it does reproduce a bit of his anterior hip pain if you look at that in the standing position. So now we're still trying to kind of figure out a diagnosis. Are you good with arthritis, or do you want to think something else further down the line? So it's standing. When I take that hip in that position, we'll call it his right hip.
Yeah.
It is irritable. And then walking, that reproduces his symptoms when he's trying to walk fast.
I'm not confident enough on him having arthritis being his main thing.
That's fine. You can move around. It's okay to be wrong. It's okay to
Yeah.
go from one to the next. So don't worry about that. It's like if you're not sure it's arthritis, what's your next hypothesis?
The capsule issue.
Okay, cool. What are we going to do for that? How would you clear that up in your mind or kind of trying to strengthen that as being, the potentially what's going on?
I'd probably do a fader or a
Okay.
favor just to like assess the different parts of the capsule.
And you already know what's going to happen with this because you could get a sense of what his internal rotation was. You're going to reproduce pain when you get into that position. Does that clear anything up for you?
I don't know.
It's okay. Just answer the way you would normally think. Don't worry about trying to give me an answer that I may want. This isn't a test.
I mean,
Just give us.
if I had a patient that came in and had these issues, they have pain with like the end stride.
Mhm.
Yeah, they have some pain in the morning and it gets worse, but he said that with long walks it makes the hip irritable. So I don't really consider that like big arthrosis. So I'm thinking more like causing so much like pressure on the capsule over and over again. That's what I'm leading to. And with internal rotation, I'm thinking it's more like that would push. That would push the hip more anteriorly onto that capsule.
Yeah. So how else could you do to kind of strengthen this idea that, okay, is it that I have a hip that's anterior? And is that what's stressing the labrum or capsular system? Or at that point too, you can think psoas tendon if you want to throw in just what would be the competing differential.
Well, what would I do to strengthen my hypothesis?
You want no, not the muscle. What would you do to strengthen your concept that, hey, I'm on the right track? What other thing could you do to then strengthen that, hey, okay, this is right?
I have no idea.
Oh, you're freezing on me, Abbie.
I know. I
Mhm.
don't know. I know that I don't know.
You don't know. Okay. Well, then you get to that point where it's like, I don't know. What would you do next?
I'd probably look at a functional squat, but that doesn't put the. I always like check functional squat on a lot of my hips just to see.
So we're talking right hip. So he goes into the squat and he gets a left transverse plane rotation of the pelvis. I'd say at about maybe 35 to 40% of the squat. And that means that his pelvis hits the right hip, his pelvis swings and turns to the left.
Okay.
Trunk stays squared up. I'll make it more complicated for you. But everyone does that anyway. So what does that tell you? Because you're looking at the functional squat and you look at it with
Right.
everybody. So when you look at your functional squat and you see that occur, what would come to your mind?
So there's rotation. There's a left rotation of the pelvis.
Mhm.
So with that,
So explain to me first what you would think. What does that tell you? And how would you infer that information, that how is this involved with that hip?
they're like trying to take weight off of the right and translating it into the left because of the pain in the right hip is how I'm thinking,
Okay.
is what I'm thinking.
What does the right hip need to do from, let's say, your osteokinematic, or let's say from an arthrokinematic standpoint, when I go into that squat position? What's that femoral head doing?
So there's flexions. There's an anterior roll and a posterior glide.
Good. So what do you now, from what the information you've had already, what would you why did you expect to see that rotation occur based on what you'd already seen when you looked at kind of the quadrant in extension internal rotation? What was this hip lacking, and how does that match with this that would create the pelvic rotation?
Okay, so it's lacking internal rotation. And so with that, with the pelvic rotation, it's causing external rotation on the right.
Okay. I get Eric's from this. As I kind of pitch this too, is as you go up in there, it needs to kind of have a bit of a posterior glide element. And when you see that pelvis swing and I see that body swing, I think of now I have the acetabulum basically moving around the femur
Right.
to compensate and create space for a restriction or limitation that creates that transverse plane rotation. Or in some cases, you'll see that early butt wink, and that's that clearing that acetabulum around the femur to get the motion, which will then create the spine flexion. Eric, your take on it?
Yeah, that's exactly how I would see it. Is you can't get that femoral head to drop back into the acetabular socket very well. And so what's happening is that's as that's locking up, it's taking the whole pelvis around with it and twisting it to that left side in that transverse plane.
Does that make sense, Abbie?
Yeah, but both of your hands did something different. So with Eric's,
I'm
his
left-handed.
locked and then no, I know, but with Eric's, he said that the femoral head kind of locks because it can't move, so that's why the pelvis moves.
Yeah.
But then
Yeah.
with you said the whole acetabulum just moves around the femoral head.
Oh, yeah, it's kind of the same thing because the femoral head can't go posterior. So what's going to happen is it can lock and the whole thing can go this way. Or sometimes is that I'm doing this around it. Okay, the thing locked. So the only thing I'm left with is the pelvis will lock and move on it. Or I'm thinking sometimes, okay, I know it's coming. My body knows it's coming. So I start to create the shift to do it that way. So it's just a matter of, okay, does it lock out and move, or do I actively move it around it? Because I think the two different ways to look at it. And that's with any movement pattern. Does it lock and then it's forced to move? Or my nervous system knows it's coming. So I change my motor strategy before that happens. And that's often kind of what you can see if you think of a restricted halocrural joint. Not often are we walking and getting to end range dorsiflexion. Like we're not loading that completely, but our body knows we're restricted. We're lacking that glide. So preemptively, we change our strategy, knowing my ankle is locked up. It drives into the thing. But not often are we getting to that pure end range motion. So sometimes what you'll find is that, okay, yeah, they're not dorsiflexing all the way, but it alters the gait and changes the strategies and does it because it creates a motor control issue. So sometimes you'll see that these restrictions will, the motor control issues there, and then we need to rehab the motor control issue after we've corrected the problem because we get left again.
Okay.
That makes sense?
Yeah.
And Eric, yeah, by all means, please, your perspective.
No, I mean, I think you explained it well. I mean, essentially, the way I would view it is, the femoral head wants to go back here. It's gonna fixate eventually, and then the whole thing's gonna go. The other option there, and this is similar to when we look at CT junction, right? If we have a patient, if they have a stiff CT junction, something that can't extend very well, when we look at that CT junction, when they look up, what'll actually happen is it'll go upward instead of downward, because everything is kind of translating forward. So what Dave's talking about is that they've developed this kind of secondary compensatory movement pattern where it's just like, well, what can move is we can get the acetabulum to move in the opposite direction. It's just now we have to adapt where the position of the body is relative to that femoral head. So you can look at it either way, whichever way is better for how you're going to view things. But basically, it's just one of those things you have to kind of take into consideration. So it's like, well, if I'm seeing this particular movement with a squat, right, they're rotating to the left. They're going to be translating to the left. They're putting more weight on that side. We may see a bit of an internal rotation of the femur that goes along with it as it kind of takes the femur with that rotation. We can see all kinds of different things like that. And it just is a matter of, where do your eyes go when you see that, when you're watching them go through this movement. But the biggest thing is if you see this abnormal pattern, right, and you're looking at them, you're staring, looking right in front of them, they're right facing towards you, and they go down into the squat, and you're just like, that didn't look right. You have to kind of make this determination, like where is this falling apart, right? So if they're having hip issues, hip pain, well, you're going to look probably at the hip, right? I mean, it's possible that there's lumbar issues or SI joint issues, or it's the foot or the ankle. But the first place you're going to go is most likely the hip, because that's the place where the complaint is. So it's just a matter of being able to see the dysfunction as it happens and then reverse engineer yourself inside your head how that sort of thing is occurring. Because you can do things to change that, right? I mean, this is one of Diane Lee's biggest things is, you just take the pelvis and you move it into a specific position, you ask them to do it again, and see if you can decompensate that stuff. Personally, I don't think that's a great method of doing these things, just because I think we see too many fixated joint segments, whether it's in the lumbar area or whether it's in the hip or whether it's in the ankle or whatever it might be. And I just don't think, kind of self-correcting those things with your hands is going to be possible in a lot of cases, right? Because you're going to have something
I agree.
that move.
Yeah, I want to fix it first.
Yeah, but if it's a neuromuscular pattern issue, right? If the joint is capable of moving and you can decompensate that stuff, that gives you more information, right? Because now it's telling you, well, when I put my hands on it and I guide them through this movement, it can get there. That likely means that we're not dealing with the true subluxation, not dealing with a fixated joint, because you were able to do something about it. Now you're into, is this a facilitation? Is this some sort of reflexive inhibition? Is it radicular? Is it, where does that come from? But the fact that you can change that just by putting your hands on it and guiding them through that sort of thing, it likely means the joint's okay, as far as mobility goes. Well, that may not be completely true, because you could have an instability that would give you that same sort of thing, but it means the joint's mobile, right? The joint is capable of moving, and that's information that we need. So again, you're just looking at it to try and figure out where's this fault coming from? Why is this particular task looking abnormal? Why is it dysfunctional when they're doing it on their own? And seeing if you can do something to change that.
So how you feeling, Abbie? Is this strengthening your line of thought or weakening your differential here?
Feeling stronger, Abbie?
Always.
After listening to that?
Always feeling so confident after Thursdays. I just want to let you guys know. I love this. It's my favorite part of my day.
What test would you do next?
What would I do next?
What would you do next? Your world. You run it.
Let me tell you something here real quick, Abbie. So, Dave, we were taking you through this thing. Dave's talking about stride stance stuff, right? So walking. And he asks you what test would you do next? And what you gave us was a functional squat. And this is exactly how these sort of things will function during an exam process, an oral practical process. Is if you give us something, we're going to ask you, what would you expect to see with that sort of thing, right? How would that look in this sort of scenario? If, your hypothesis is X, how would that look? So when you give us something like that, you got to be aware that you have to be ready to give us the answers for those sort of things too. So that's a good lesson to learn.
Yeah, I'm learning. I'm just giving you guys sarcasm like I always do. It's fine.
I know it. I know. I'm just trying to point out that that's
It-
exactly how that would work during an
Yeah.
exam.
Yeah.
I
And it
mean,
makes it
I would.
way more fun for me if you keep the sarcasm. So definitely keep it.
Yeah.
Oh, I will. Don't worry.
Okay.
Okay. So next step. So, I mean, would I watch? I probably would put him on the treadmill and watch him walk, see what kind of issue there is up and down the chain that way. I'd watch
Good.
him walk
So
before I'd watch him run.
I was hoping you wouldn't say that, but
Okay. Sorry.
okay. He's walking on the treadmill. As I mentioned, he's probably about 6'3". So he has a long stride,
Mhm.
and toward late stance, what you see is he extends his knee, almost creating almost like a plantar flexion moment or a neutral moment at the ankle in late stance to toe off. So again, long stride, the knees moving in the very late end part of stance and heel off and toe off, the knees moving actually into extension. There's an extension moment there that's happening in late stance to toe off. How would that
Okay.
possibly increase stress on the anterior hip?
If I'm increasing extension
I
at
can't see you,
the
so you should be
knee.
standing and doing it right now to see what you feel. 'Cause I can't see you.
So I'm increasing knee extension. I feel like I'm contracting the quad as I extend the knee. So you'd be pulling at the anterior hip with the excessive knee extension at late stance and toe off.
So that knee moving to extension, you're saying it's going to drive the hip forward, which would be correct.
Yeah.
Does the long stride change the stress at the hip? What does that do to the hip?
The long stride change at the hip.
Would that increase stress in the posterior hip, anterior hip, or would that not really be a factor in what he has going on with groin pain, anterior hip pain?
I mean, because it's such a long stride, he would have a lot of extension. So it would just really pull at the anterior hip.
Okay, so that's kind of going on there. Okay. So where are we in time? Okay, good. Let's go this route. Yeah, you can see that that's it. So what would you do next with them? So getting pain with that position, you put him up to 4.3 miles an hour. So it's a brisk walk. He's feeling it in his anterior hip at that pace. What would you do to kind of, in a test retest model, see could you change it?
Tell him to shorten his stride.
Could do that.
Or
Still gets the extension moment at the knee.
would I have him? Would I see? I mean, if he's still getting pain, I just I'm timid to have him start running. Then, if he's already feeling pain with walking at 4 miles an hour.
You're gonna have him start running?
No, like I feel timid about doing that.
I would too. What don't you
Because
know
we
yet?
already have
What,
where the
what-
issue is causing the anterior hip pain with his walking.
Okay, so you have a couple aberrant patterns here, and you saw him on the treadmill. What would be good information to have next on this individual? So you have an aberrant pattern at the knee, you certainly have something going on at the hip. What type of exam might be helpful at this point to make sure you know the lay of the land?
Want to do some strength testing?
Sorry?
Strength testing?
Okay, that's one. He's got a good 4+ out of 5 with hip flexion. It breaks when you start to go 4+ out of 5 to 5. Abduction's kind of the same. It breaks under high load when you do it. The rest are relatively normal around the hip.
Hold on, can you repeat that? Sorry, I had someone come in.
Assume that again, when you get to 4+ out of 5 in seated testing hip flexors or supine, it breaks a little bit at that point. The same with hip
Okay.
abduction.
Okay. So,
And he gets a little bit of irritation with it, but it doesn't necessarily reproduce the symptoms purely.
and I need to look at, so what other testing would I do? I might even go and look at, like, look up the chain and see what's going on in the back and see if he has
But-
like,
but- Now, would the back be the most likely thing to refer down, or would something below be more likely to refer up? Or
well,
drive
if he's
this upward?
having this increase in the extension, it probably is something driving up.
Okay. So I might save the back and thoracic spine
For later.
for as I got deeper. I probably look down and get a sense of the lay of the land, and making sure, do I fully understand the biomechanical eval of the hip, knee, and ankle?
Uh-huh.
Does that make sense?
Yes.
Okay. So what would you like to do next?
I want to I want to slow him down and I want to watch what's going on at the foot
Okay.
on the treadmill.
Okay. So we look at his foot. Talocrural joint, normal glide.
Okay.
Okay. His rear foot is stiff. It's a stiffer than normal joint, but it's not restricted, and it's stiff bilaterally and equally.
Okay.
We've got a bit of excessive mobility in the naviculo-medial cuneiform segment. And we have a restricted arthrosis at the first metatarsal MPT joint. Explain to me how the two things in the foot relate to each other.
So if there's excessive mobility at the naviculo-medial cuneiform joint
Yeah.
and decreased restriction at the first med, or
Yeah.
decreased
And
extension.
it could tell it's arthritic. It was suffered a injury where it got bent downward when he was playing football with his son years ago, and basically developed arthrosis.
So there's excessive motion at the talocuneiform joint because it's trying to compensate for extension at the first. It's trying to like extend that area more to push off.
You're probably going to have, when you have restriction there, you're going to have something else go on there. Okay.
Right. Right.
Does this have anything to do with the other things that he has going on in gait? Let's look at gait first.
Well, if I'm lacking extension for push off and I have excessive mobility in the midfoot, then you're not getting that full push off and extension. So that's why you're having to pull you, or that's why you're having to like contract the quads to for extension and late stance for more extension for a more powerful push off.
Do it again. So which motion is that explaining? Is that explaining what you're seeing?
With the
Anything up the
stride.
chain? Yes.
Yeah.
So
it's looking at the back, the extension stride.
So in late extension, what was going on?
In late extension, you don't have that 60 degrees of great toe extension that you need. So you have increased mobility in the midfoot to get more extension at the other parts. You don't get enough. So then it goes up the chain.
And
And
what did you see at the knee?
Knee extension.
Late stance. Does that make sense
Late
with what we're seeing?
In my mind, it is, yeah.
Okay.
Actually, I'm making sense of this.
You're hanging in there, Abbie. Definitely hang it in there.
Doing my best. And so the way I'm kind of seeing it is you're trying to create more extension at the knee for a more powerful push off. Am I not seeing that correctly?
Yeah,
Why would you need that? Why would you think you'd need that?
Because because you can't push off your foot enough. So you're like creating more extension in the knee. That
So
works down the chain.
you're thinking along the lines of that energy transfer, right? That passive energy generation, right? Where you're thinking something's not going right here in the foot, and so we need to develop more. We need to add that energy back into the system. Is that what you're thinking?
Yes.
Okay, and you're thinking they're doing that at the knee by forcing more knee extension.
Yeah. And like knee and glute, like because I feel like once you like how I'm visualizing it is you extend the knee and you're also contracting the glutes, so that helps with push off as well.
Your head's in the right place, but I think you're seeing it a little differently than what
Incorrectly.
I'm thinking. Yeah.
Got it.
Because essentially, once your knee is fully extended, you're not going to get anything extra out of that quadricep.
Right.
Right.
But I just
So-
like you're contracting it at late stance for that push off is kind of how my thing
Well, the
is
point
so
is
long.
once your knee is fully extended, you're not going to be because the knee's no longer going to move, right? So you can't add any energy into the system with the quadricep once the knee is in closed pack.
Okay.
Because the lever's gone. The lever that it affects is the knee, right? Most of the quadricep is anyway. So once it's fully closed packed, you're not adding anything in because there's no actual movement occurring there.
Okay.
Does that make sense?
Yeah.
But I do like where you're thinking about this sort of thing. Just think about it from a different perspective, or more aptly, think about it from a different joint.
Okay. So I need to keep talking in circles is what you're telling me.
No, I think your thought process is reasonable here.
Yeah.
Okay.
But I think you're just missing a little bit of it because when you're thinking about a joint, so if I look at my wrist right here, if I want to add energy into what my arm is doing, I have to be able to move that joint. If the joint's
Right.
already fixated and it can't move, if I'm contracting that as hard as I want, as hard as I can't add any energy into it because there's null movement occurring at that joint, right?
Right.
So where can you adapt some movement?
At
Or
the
more
elbow?
likely, more aptly is where is this patient doing that?
Oh, at the hip.
Right.
He's
And they're
doing
doing that by doing what? They're forcing that translation.
to get more extension.
That's what I would think. I mean, Dave knows this person, knows this case, so he can tell you better, but that's the way I would see it.
Yes,
Okay.
there's the two sides. There's two sides to it. I look at the two sides. I absolutely get where I'm heading with it. And then the other one is that okay, if I get in, it's that other there's always the corollary to it, which is that okay, he doesn't want to load this big toe. Yeah, this thing's not going to take energy. It can't transmit energy. So it's almost like it's like a pressure valve being blown. Is that when he goes to load that big toe, when he extends that knee backward, it's going to basically not load through the big toe in the ground map. It's his way of creating an unloading moment laid in there, which is going to be driving then through the hip. It's the same thing. It's just a matter of what is driving it, is kind of how I'm looking at it versus that. Eric said in the hip is exactly correct.
Okay.
But the idea that now the way it kind of gets generated with this compensatory motion being that thing is that okay, I don't want to load and I can't load through this toe. It doesn't have to store energy. So my strategy is going to be to move it up, create an aberrant moment in there. And that's that idea of motor control and how his neural system winds around it, how we can have an articular restriction, which is going to drive the neuromotor patterning and drive it up through the hip, whether he's trying to get more room or whether he's trying to avoid a painful segment. Because we're not going to be able to change we have a difficult time changing the toe. We're probably not going to change that.
Right.
It's been there a few years.
So, right.
Think about if you start to step on a Lego or something like that, right?
So,
You're not gonna want to put your whole weight down on that Lego, right? You're gonna try and adapt to that and lift the leg up, right? So that's what he's doing. He's pulling that knee back in order to avoid putting weight on that painful spot. Same thing if you're stepping on something that hurts, right? That was a very confident,
So what do I do then with this guy? No, like it makes sense. It makes sense. I feel like, okay, I found the issue. Now where do we go?
That's
Because he
perfect, Abby.
still has difficulty
That's my
with.
next. It's great you mentioned that. 'Cause that's my exact next question. Okay, Abby, what are you going to do with this guy?
Um, well, I can't fix the toe, like you said.
Okay. Well, so what can we do for the toe?
It's ready. You can do some joint bulbs on it. You can see if it'll move a little bit, but you said I can't fix it. Those were your
Okay.
exact words.
No, but we can accommodate. We're going to look at, we need, how do we accommodate or move around it? Maybe one thing we think about doing. If this is the primary driver. Now he still has a hip pain. So he knows the toe is there. So we're still going to kind of relieve his hip pain with the things that are going on in there. So the question is, does he need his compensatory pattern, or has he maladapted it because of the Lego effect?
He's probably
It's a great term. The Lego effect it's a great way to think about it.
Yeah. He's just adapted to it.
Mhm.
Incorrectly.
Yeah.
Creating the pattern.
So a good starting point may be, test the retest model. The easiest thing to do with him, well, one is you'd be looking at them to make sure is it a manipulable lesion? Is something I'm going to manipulate according to neuromotor retraining with this restriction? So if I had more time, I'd take you up to the hip. But again, what do we have to do? Does he need that extension moment in late gait? Or has that been a maladaptive strategy? Best you hope for is that it's a maladaptive strategy that he doesn't need. He can kind of come off of that toe without pissing it off tremendously. And still have a normalized gait, because we're looking at his primary complaint is anterior hip pain when he's loading it. So how do we decrease that moment and that stress vector on the anterior hip with walking and movement pattern?
I would say you try to work on like decreasing his stride. So you decrease the amount of extension of the hip.
Mm-hmm. Increasing cadence. Okay. Yeah, we're gonna do is we got 10 minutes. You see him, and that helped a little bit. You saw him first session, you trained him on his gait and his stride. Okay, I'll give you manipulated his hip, and he gained basically 10 to 15 degrees of range of motion, felt a bit better. It wasn't perfect.
How did I manipulate his hip? Did I do a Ufer thing on him?
Yes.
Okay, wonderful.
Okay, so I'll give you that. And he comes back, but he still gets it, especially when he's walking. So you're like, okay, let me look at him walk again and see. And we see some of the same things. He's controlling it okay, but he's having a hard time controlling it. He's 6'3", he's 51, he's slightly kyphotic, which is mildly for his age. He's still pretty upright. He has no arm swing. How does that potentially impact irritation his anterior hip as he's walking?
Well, if he's kyphotic and he has no arm swing.
Mild kyphotic, very small. Not much, but just a little bit.
Well, there's just like no rotation happening. He's not letting his body like move, like absorb all the ground reaction and the gravity forces, and it's just like all being pushed through the hip.
Good. But how does the arm swing come into play with that? What would the arm swing do to potentially to the right hip?
Yeah, what does the lack of arm swing tell you, essentially?
But they're lacking motion in the thoracic spine.
Sorry.
Yes. What does it do to the hip?
I work very heavily with my arms, so I can't think about this.
Today we're gonna can any of your coworkers hear you right now?
Yeah, the office door is wide open.
Oh, good. Then have one of them strap your arms to your sides and
I'm
have you
walking
walk
with my
around the
arms
clinic
by
for
my
an hour.
side. I'm walking with my arms by my side right now in the clinic or in my office. Okay. There's just like no trunk motion happening. No. So I feel like if there's no trunk motion happening, That also can decrease the amount of pelvic rotation, maybe?
Decrease it?
Yeah. No, it would increase it because it has to compensate for all the way up.
Got to come from
Mhm.
somewhere.
So it would increase pelvic rotation because I'm lacking trunk rotation.
Mhm. Yeah, that force has to move through the system, and you're not efficiently being able to wind it correctly. Kind of like what Eric talked about in the previous few lectures too, right back around,
Mhm.
and how we're storing energy and the gate being driven from the spine. So,
Mhm.
Well, and think about it, right? So when we were talking in the last couple of sessions, when we were going through that PowerPoint, what was it when we're talking about Grakovetsky and his articles? What did he say was the actual driving engine for gait?
Ooh.
Does it come from the foot?
Well, we talked about the foot last time, so no, it doesn't. You're shaking your head no.
No, it doesn't, because right, remember we're talking about the legs are just an additional pendulum. They're just increased lever arms for us to become more efficient. The driving mechanism for gait comes from where? What part of the body? What region of the body?
The trunk? The pelvis?
The lumbopelvic area,
Mhm.
right? So is major, the multifidi, those are the ones that are really going to drive gait for us, right? That's what what he called the spinal engine, right?
Uh-huh.
If you're not able to distort the trunk, right? Because we talked about the idea that what does the psoas do, right? It's going to put us into extension, ipsilateral side bending, contralateral rotation. So if you're not physically able to do that through the trunk, what are you going to demand out of the lower extremity, the lumbopelvic region, etc.? You got to add that back in somehow, right?
Mhm.
So you're going to be working much harder on the lower half in that lower quadrant area if you're not getting adequate trunk mobility. You have to, because essentially you're turning the engine off here and you're running on fumes.
Right. That makes sense.
Does that make sense? Okay, good.
It does, yeah. So, Dave, to answer your question, I'm gonna work on his arm swing.
good. How you gonna do that?
I'm gonna teach him how to work, like walk with his arms, of course. But then also, I'm gonna look at his thoracic spine, see if it's like lacking rotation. Gonna look at the shoulder girdle. We're gonna look at it all. We're just gonna do the whole thing.
Okay. Which thoracic joint are you gonna look at first?
Oh my gosh. Oh, for rotation,
Hmm.
T11,
Okay, and why?
because that's the most rotational area in the thoracic spine. I think it's T11.
It is. It's the
I'm gonna
most
look
mobile
at.
joint.
Mm. See, I
It's
had to
restricted
study it.
into, won't go into left rotation. And
Left
I'll go back. I don't know, I
rotation.
ever gave you the information earlier. His hip is centered somewhat anteriorly on the right.
Mm.
Does that match up a little bit, or does it not? Is it congruent or incongruent with the two rotations?
So the hip is sitting more anterior
Left hip, right
and
hip is anterior, and the pelvis has a slight anterior rotation. His thorax is T11. We're gonna look at that segment. That segment goes to the.
it
It won't
can't
go.
rotate
It's
left,
restricted
so
to the
it's
left.
translated right.
Yes, it's
Okay.
restricted to left. I think I got it right. Yeah.
Well, where would
Dave,
you?
if you don't have it right, I prefer don't have it right.
Well,
Yeah, that's
think
what I'm
about
trying
what if he's having issues in push off on his with his right
Mhm.
leg,
Right.
right? That terminal stance
Mhm.
position. So the right leg's
Mhm.
trailing behind him. Which arm should be forward?
The right,
The right
causing left
side, which
rotation
would make his trunk rotated which direction?
to the left.
To the left.
Yeah. Okay, so
Did you learn a technique for that?
I'm sure I did, yeah. Mhm.
Which technique might that be? I tried to get to it while Eric was drinking just to see if I could get him.
Oh my gosh. Well, isn't it T11? The whole segment? Like the whole ring? It's not even a
Yeah.
ring. It's a floating rib. Do we consider floating ribs rings?
Not really.
I don't.
Okay. Okay. Great. So I would do a sideline technique then for a T11.
What are you going to correct? What are you correcting here?
So it can't rotate left. I want it to rotate left. So it would be a
Mhm.
right rotation
Mhm.
subluxation.
Okay.
So I
Good.
would,
So you're going to flex extend or you're going to rotate?
um, if it's the whole segment, I want to rotate it.
Okay.
That's hard
Sounds
to
solid.
do. Yeah.
Sounds solid to me.
Thank you.
Not hard to do.
Mhm.
I haven't done that in a while.
Yeah,
Okay.
it's a
What-
rotation technique, PL junction.
Yeah. Yeah. You're right.
So you're gonna basically you want to stabilize the lumbar spine, right? You want to keep the lumbar spine from having to do any of the rotation for you. So you're gonna flex from below, right?
Mhm.
You're gonna take the knees up, bring the knees up so that the hips are in almost a flexed position. Tighten that supraspinous ligament, tighten the thoracolumbar fascia. That's gonna stabilize the lumbar spine for you, right?
Right.
Up to T12. That's gonna hold that whole thing together. Then you're gonna rotate from above. Use the arm, lift the arm, rotate in neutral all the way down to T11. And then all you
Are
have to
they
do
in
is
left
just take,
sideline or right? Oh, wait, no, they'd be in
they'd
right
be in right
sideline.
sideline.
And then flex up to T12, rotate left, and then push the segment straight down into left rotation.
Correct.
Okay.
The exact same way you would test it.
Right. You would
The only
just
difference
add a
is you have to
thrust it.
fixate and then produce a thrust.
Mhm. Yeah, that's not bad.
And technically, what you're really doing here is you're not only doing rotation, you're also doing flexion and extension. What
Because
you're
you're
doing
doing the
is you're
whole
taking
segment.
the left facet and extending it, and you're taking the right facet and flexing it. That's what happens
Right.
with rotation. We get equal and opposing movements on opposite sides.
Yes, we do.
All right,
And
Abbie.
then
Okay.
is he all better
Okay.
now?
Now he's complaining now that his right clavicle hurt.
Jesus.
It's 1:00. I have another meeting to get
I'm
to.
afraid we're out of time, she said.
Oh, rats. Boy, that would have been fun. Because I was just making stuff up right now.
Okay, like
Good
that
job.
wasn't bad. Would I have passed it?
Eh.
Eh,
But you know what? Here's the deal. We haven't done module 8. Everything changes. We do this a lot in like module 8 and going forward. It is so different now that you start tying it all together and it gets very fluid. That was very good.
Okay.
Like we don't mind
mean,
walking.
I think once Eric made the point of like, I was told that it hurts with extension, like why would I do a squat? But then being able to explain that and then going into like, I actually know more than I think. It's just really
Exactly.
trying to really think of it from each joint and like what each joint is doing. So it's just more studying on my end, but I think this really helps to know what I need to look over and like how to look over it.
Putting little notes and cue cards that when I go into clinic, let me practice looking at A, B, and C in different people, even if they don't know I'm looking at it. It's tying it all together. It's like you have all the individual joints and all the inflammation. It's now understanding quickly. I think you got big toe. You figured out the knee from the big toe. You saw the levering through the hip. You saw the global picture. Okay, and that's kind of what we want to see, is that you could pull the global picture. You didn't freeze.
Yeah.
So I'd feel good about what you did today.
Okay, cool. Thank you very much.
No problem.
All
All right, you survived.
This time.
For another week.
You
All
caught
right.
me on a good Thursday.
Yeah, we'll see how you do next Thursday.
Yeah. All right. See you guys.
Take care. Bye.